I ask her to side flex to the left, she can perhaps do that because this is already posterior, side flex to the right. She won't be able to do that. It'll go down to the right like that instead of twist forward, and there'll probably be some greater effort for her to side bend, or the side bend will be restricted and she'll try and compensate somewhere. So none of these things can be taken in isolation. I mean, they're so fraught with things going wrong with them. Now then, what are the other things that we can tell from this standing kinetic test, or the kinetic test on the moving leg side? Well, we can sometimes get a sense of the direction of the joint surfaces. Can you come up a bit, Kathy? Stand on your left leg, bend your right leg up in front of you. By feeling here, I can get some sense of whether this is happening or a little bit more that's happening, which might give me some idea of a direction of correction. You know, so say I'm going to produce an anterior rotation to correct this so-called posterior rotated ilium, then if I felt that there was a bit of movement in that direction, and it felt as though the surfaces were like this, I would tend to put my push in that direction. If it had felt a little bit more here, I'd probably tend to push a little bit more in that direction, just so that we're trying to accommodate rather than jam up the surfaces. So there are a number of things that you can feel from this. Now, thanks, Kathy. We had some good discussions. Rob was bringing up a point, you know, from Shirley Sarman's course. I haven't done her course, but I've attended a number of lectures, and I was always really, really impressed with the stuff that she did. But she's looking at the hip in terms of recruitment patterns and all this, and that would be where she would start, because that's her orientation. Muscle energy people say, look, if you've got a sacroiliac joint problem and a lumbar spine problem, always treat the lumbar spine first, because many of these other things are secondary and they clear up. If you'd trained in Germany with the cell group, what you'd be doing now is always looking at the pelvis first, because they believe that the pelvis with the position of the sacrum is going to set what happens above it. And if this is all distorted to start, any movement that occurs from there as a base will show problems. If you'd trained in the Logan School of Chiropractic, you'd be kind of looking at the CV area for the hole-in-one approach, because they believe that this is so much related to neurophysiological postural changes that if we've got a problem here and a problem there, you would always start here and things would change. So it depends what your training is as to what approach you make with these things, unfortunately. My feeling about the pelvis is that on the whole, mobilization of this is not fraught with doing things wrong. Say you've got it back a bit and you do some of these pushes. Because of the strength of this area and the tendency to go to slight stiffness, mobilizing this in most people, apart from people like Becky, which you wouldn't want this, but for most people a bit of mobilizing is a good thing to do. So I think you've just got to look at yourself and say, you know, what do we do here? Because if this is all twisted and I come up like this and I recruit like this, is it because I've got some alteration in the strength of my iliopsoas or something? I've got to do it like this. So I start working on the recruitment patterns. My success with patients on working on muscle, where they've got to kind of think and do something, is not probably as good as it should be. So I tend to kind of work on mechanical things that I can influence rather than expecting them to influence much. Now, if after a couple of times they're still doing this and this seems to be okay to me, then you've not hit the right emphasis to start with. And I think then you've got to review this. And I think this is the whole business, isn't it? That we expect to find some change in the dynamics of the situation early. And after a couple of treatments, if this isn't changing, it may be we've got to do more of the same, but it means that we've got to reassess and see if this has changed, but you're still doing that, so I'm going to look for the next pattern that's in your mind. And so I think this is variable. Who knows who's right with a lot of this stuff, but I think if we can make a list out Okay, and just have a look like Maitland did, of salient signs that he's finding, and then he asterisks certain things that he's going to test to check up on improvement, and certain things that he's asterisks, which means that's how he's going to, this is the window or the door that he's going to go in to try and influence this stuff. And if it isn't changing these salient signs, we look at all this again and review and say, okay, this could be caused by that, or it could be caused by this. I chose that, but it's still there. So now let me go to this pattern and work on this. And I think that's the right thing. But as I said yesterday, I don't think that's the way to talk with patients. Okay, we've got this and this, and I don't know. You know, I think what we should do is to say, there are a number of things here, and I'm going to treat them sequentially. So they think now, geez, I've got somebody here that really knows what they're doing. They've sort of picked up the whole pattern rather than sort of scratch your head and sort of not know which one's important. So I think this is a matter of communicating, because as Chris was telling us yesterday, we don't want to increase the alarm reaction very much by, you know, quizzically looking at all these things and then them saying, well, you know, do you think I'll ever get better? You know, so this is sort of, I think, how we work. All right. Now, the next thing that I would just like to do is to have a look at a couple of corrective procedures for the posterior rotated bones. And I'd just like to say to you at the moment, I'm being very careful, and I'll be even more careful when I get into the muscle energy terminology, that a fixed position, okay, like fixed, ends in ED, and so every time we use rotated, side flexed, ending ED, it means it's held in that fixed position. Whereas if we use the term extension or rotation, that ends in ION, and that's the end part of motion. And so it's kind of good that if we use the term a posteriorly rotated ilium, then the correction is going to go into anterior rotation. Now I'd take just a little bit, not an exception to what Earl's got in the notes. This is a slight difference of how I would describe this. He's had a look at the motion of the leg, and he's placed the ilium as part of this leg mechanism and suggested that perhaps we could use the term anterior rotation with extension of the ilium. But I bet if you ever talked out there about extension of the ilium, nobody would know what you were talking about. Whereas if you use the term an anterior rotation or held in anterior rotated position, everybody would know. So I think that I'm very much against changing terminology, and particularly if we're using terminology that has perhaps another meaning to somebody else. If we think of another word, then perhaps that's different. But if we are using words, so I think I would say I don't agree with changing. It's like what happened with Friot, when he decided that this backward bending movement was actually flexion of the spine, because it's increasing the curves. And in terms of physics, he's absolutely correct. But now nobody knows what he's talking about. Is this extension? What are you doing? Are you doing this? Or are you kind of making the curve longer? So it would have been a lot better if he'd just simply ignored that, let people that use flexion and extension use it, but he used forward and backward bending. Nobody has any difficulty with those. It kind of fits the system. So I think we've got to be a bit careful about changing terminology. Do you know all the problems we had when McConnell started changing pronation and supination from what the average orthopedic description of this was, which was the all-force position, coming into pronation? He went the biomechanical route. Now nobody knows. This patient has got a supinated foot. And the doctor's looking at this and saying, is this therapist crazy? This foot is a pes planus. It is pronated. You know, so if we're using terms that have got a different meaning to another person, especially if it's exactly reversed, then it makes us look as if we don't know what we're talking about. So I think on the whole, you sometimes have to fit, not with what is accurate, but what is the general usage. That seems to be reasonable to me when we are communicating with other groups, because we're not primary care people, because we're referral people, we've got to constantly have this back and forth communication. And so we need to stick with terminology that's acceptable to everybody, even though we have to kind of bite our tongue a bit because it's not totally accurate biomechanically. You know, but we can kind of have diarrhea over that, but still come to terms with it. All right. Let's have a look at a very, very simple procedure for correcting a posterior rotated ilium, or what the osteopaths call a posterior innominate. Those two terms are pretty well understood. I think wherever you went, everybody would understand what you were talking about with that particular thing. All right. Chris, can I just use you for a minute or two? Just come and lay on the stomach here. Yes, please. Just lay on your front, please. All right. Now, if we have a posterior innominate, okay, we've got the features where this posterior superior iliac spine has become more caudal. And we can start producing a movement forward. But before we do that, let's think of a fairly ubiquitous technique which just loosens the joint up a little. And so I'm going to ask Chris to lay on his left side. And we'll use that test that we did yesterday for feeling movement in side lying. And I'll kneel on the bed here, so Chris can kind of lean onto my knee at the back here, and I can get onto the anterior part, lateral part of the anterior superior iliac spine. And what I'm going to do is just to lean on Chris like this, and I'm going to produce what would be called in muscle energy circles an inflare, but I'm just trying to gap the posterior part of the joint in a rhythmical way like this. I can do it by doing on and off like this. Just tell me if any of these are painful. Okay. This is usually a very sort of non-threatening kind of movement. Okay. Or I can take it to the extreme and do some little end range movements like this, right at the end of the range. If you wish to feel what's happening, you can monitor a little bit or even try and pull around from the back. But I feel that the lever over which you're working here makes this relatively good for stretching the back of the joint. Of course, it's got the problem of compressing the front of the joint. So if the patient had a deep pain right in the groin at the sort of back somewhere that they couldn't really define, then this is probably not the way to go with this particular thing. But I find this has never caused me having people sort of grumble about it. It always seems to be a very useful, ubiquitous kind of test for just about any displacement. It just loosens things before we start into trying to correct. All right. Now then, I'll get Chris to lay on his front now. And there are lots of techniques, and I mean, you could sit there with your partner and make some up quite easily. And I think this is all right. But I'm not going to try and give you lots and lots of techniques. Let's just go over 3 techniques for this which seem to work very, very well. Now, I'm going to hold on the apex of the sacrum, and I'm going to come onto the posterior superior iliac spine there, and I'm going to make sure that the anterior spine isn't just pressing into the table. So with these tables here, it's ideal because we can get him to come back to the split in the table so that now he'll be supported above and below, and that anterior spine will go into the split. I'll get him as close to me as I can. This is fine for me here. And I'm just going to take the ilium forward like this and then do a series of little motions like that. Now, because this is a very tough joint with a lot of stability, possibly we break that rule occasionally of holding with one and mobilizing with the other. And perhaps we mobilize with both, coming like this. But certainly to start with, I would try and sense where I'm going. Now then, when you're pushing, one of the things to do is to just take hold of the posterior iliac like this and just push forward, and then try and change a little bit the angle that you're pushing at. Now this jams it up when I kind of push down here. I can feel that. And if I go too far that way, I can feel, so I'm kind of pushing that way, that it's not so good. Somewhere between those two, that feels the best freedom of motion in this joint. So try and sense if there's an area, even in this stiff joint, that feels a little bit better, and just work it in that range. Okay, so this is the first thing that I'm going to try and do to mobilize this joint. The next thing that we should do is to think to ourselves, okay, not much is happening here. Can I use a slightly longer lever? So I can lift the leg like this, make sure I don't pull him off the bed, of course, come into this position, hold it there, and then sort of move on the apex of the sacrum into that way. Now, I don't like that particularly, but what I do like is this, that if we take up the joint structures in front, such as the iliofemoral ligament stretch, that we come up into a position that would take the ilium forward, and I lift the end of the table up, okay, so that the split will be below the sacroiliac joint. Then I can come into a position and further augment my action, having pulled the whole thing forward by the position of the leg. And of course, we're going to be in a position to use some of those muscles to pull it forward when we think about the muscle energy augmentation of this. Now, as I'm going like this and as I'm pushing forward, one of the difficulties would be that we'd start to perhaps increase the lordosis in the lumbar spine, so that the correction for that would simply be to bring this leg and drop it down on the ground. Keep him close here, all right? And now I'm in a wonderful position. That flattens the spine. I hold him from coming off the bed like this by putting my leg just under this pelvis on this side, so he doesn't feel in any way insecure. Then I can come onto the base, or to the apex of the sacrum, posterior suprailiac spine, and now I'm in a very nice position to push forward, having tried to eliminate a number of factors, and particularly the lumbar spine. But we don't want to pull the leg up into too much movement here, otherwise what we've got is major tension over the psoas muscle, which of course in this position is trying to pull the spine into lordosis. And we'll talk a little bit about stretching of this, because we're getting into some principles of stabilizing the spine while we stretch the muscle. So we don't want it stretched too far back with this leg. But I think that this little group of movements, particularly the one just lying and just moving to start with, having previously prepared it by the side lying technique, and then coming into this as my major technique here, I found this to be a very, very useful mobilizing procedure. Then we'll have a look as we go at which muscles might hold it, and we'll stretch them, and which muscles could augment this, and we'll make them work, so that we've now done like a very, very specific muscle energy technique. I have problems with muscle energy. I don't think that they utilize sufficiently well all the principles of localized movement than we do. So I think we can improve on what's being done out there by a great deal. And so this is what we'll do. We won't do the things that you'll find in the books. We'll do the ones that specifically localize things to the particular area, so we don't get spread all over the place of muscle action. So can we do those? The side lying, this one, just get this feel. Get this. And of course you're very close to doing the position from any place. That's the only difference, is just taking it, working it, and a little impulse. So within our whole range of things that we're doing, we don't have thousands of different positions that we do things in. For each different little section, whether it be muscle energy or whether it be mobilizing or it be manipulating, we try and use the same principles, if it fits perfectly, for each of the different procedures. Let's try that, please.
From the greater trochanter to the knee. Did you see that? Did you do that at all? The one that Earl taught me. What am I
All right. Let's have a look at the next phase of this, can we, for a second? Which is If we're trying to produce an anterior rotation to correct a posterior rotated ilium, all right, which muscles would hold it posteriorly rotated? Which are in the ideal position to sort of keep on making it revert to its original position. Hamstrings, perhaps the glutei, and so on. Of those, which is likely to be the problem? Hamstrings show more tightness in my experience than glutei. In fact, glutei, I think the problem with glutei is more, from Yanda's work, of a weakening effect. The flexors shorten, the extensors of the hips without the hamstrings. I'll sort of list these out a little bit later. The extensors of the hip tend to shorten. So what we're looking at basically is a hamstring involvement, and this is something that we should stretch. Now, what I think might be a good idea is to just leave the stretching around the hip till we perhaps do the hip and just sort of do the whole thing and say, look, here are a number of combinations of things that we should be doing, and try and fit it so that we can get 30 pages in our minds in less than 30 pages, okay, of technique. So, what muscle could bring about a correction of this? What ideally is in the position to bring about a correction?
Rectus.
Okay, rectus might, because it's going to the, where? Yeah, the inferior anterior spine and that little reflected area above the hip joint. What muscle goes to the superior iliac spine that's anterior? Sartorius. Okay, what muscle is even more important than either of these, although they are working at a lever system? Not psoas, because psoas works the lumbar spine. Iliacus is the really important muscle, I think, in this regard. So, for him, I would, with Chris here, can you come over to the side of the bed? I'll stabilize everything like this. I lift up the end of the table to the critical point so that we've got some extension of the hip, but we're not taking all of this into this counteracted spine here. And then, having got the table all lifted up, and for women this is really important, certainly working on a magnificent specimen like Chris here. Okay, so I'm just going to lift the table up there. All right. Now, what I want to do now is to direct the iliacus action, but I don't want to be resisting it. Because, I mean, this is a big muscle. So, I want to come in and hold the apex of the sacrum, and I'm going to ask Chris, the table's doing most of the resistance, but I want to feel that's going on. So my hand just gets inserted between the leg and the lifted up table. Okay, Chris, can you pull forward? And because we've got the knee straight, it'll augment also sartorius and rectus. Down again, and let it go. And down again, like this. So we're going to get a series, muscle energy people suggest about 5 seconds, but whatever. Just push down. That seems to be a reasonable period of time to me, for me to hold it, and for him to do this without getting cramps and things. And down like this. So that we can now just think to ourselves, all right, I've done some of this. Now, can I start working and make him do some of this work? Pull downwards. And so this would be the muscle energy procedure for this particular position. I'll show you a couple of other kind of techniques for this in just a moment. But that would represent a muscle energy approach to this. Now then, can you lay and face me, Chris? And I'm changing the mobilizing joint now to this side so that the camera will get the angle here. And if the table lifts up again, very, very useful. So, I've got the table lifted up to absorb the weight of the leg, because I don't want to hang on to the weight of the leg, all right? So I'm going to put this leg on here, and it's going to go back a little into extension, because I'm trying to put the iliacus into a good middle to outer range position, but also to bring the ilium forward like this. I want to counteract the tendency for this extension of the hip to extend the spine, so I bend this leg up here and I can control that. All right, so now with Chris here, his leg here is supported because I mustn't be carrying the weight of this leg. I mean, that's just going to be too much for me to do. So I now come around here and my heel of my hand goes on the apex of the sacrum, and this hand just holds it in there. So this will be much more into muscle energy now of a very specific nature. Okay, can you push your leg, this is the top leg, into my shoulder? So he pushes like this, and the only movement theoretically that can take place here is this motion of the ilium coming into anterior rotation to correct a posterior rotated ilium. So I can pull around here, push forward, and let it go. And you'll see this at the back of book 3. Push forward, where I've sort of done some photographs. Some of them are not quite as clear as I'd hoped because my daughter was taking the pictures. Push forward and she didn't really know what I was looking for. So, and down again. And again push forward. Like that. And relax. So.
David, excuse me, I understand what Chris is doing. I understand what you were doing with your left arm around the ilium.
Okay, no, my left arm is over the ilium like this. It's got nothing to do with the ilium. It's coming down onto the back of the sacrum. And I'm on the sacral apex. Just the same as when we're in that other position, you were holding on the sacral apex. We've got to stabilize the sacrum.
So it's just a stabilization. You're
Yes.
not directing any force or anything.
Because if I don't do that, the sacrum moves on the lumbar spine. This is the problem of a lot of these techniques. They don't stabilize sufficiently. If you're saying this muscle's going to do this, but if this joint's stiff, it sort of produces movement elsewhere, then of course we just dissipate the energy. And I think you need, in these things, to have the energy directed to an individual joint. So we can do it in our standard position. This will be the last position I'm going to teach you for this particular area. I mean, we don't want to keep on just getting more and more kinds of movements for a particular positional fault, but just around here and then just let the patient push. But you don't want to be kind of turn the weight to the back here. I mean, let's make things as specific as we can for ourselves. The other thing is that you think to yourself, well, am I in a bad position here for my own back? Well, not really, because in the Norwegian system, they've developed this kind of enveloping thing around patients. So with Chris here, his weight is taken, I'm leaning on him. So that takes away just about all the strain from my spine. And this is very important. You want to get 50 years of work out yourself, Pat, don't you? Are you kidding? So this is what we need to do to protect ourselves, and this does it perfectly. Just lean on the patient. They get a feeling of specificity, and you get a feeling that you're saving yourself. And so it works very well for both. And the techniques generally seem to be very, very close from one treatment to another when you're doing this sort of enveloping stuff. All right, so let's try this. You can imagine both of these two techniques over the side of the bed and this one are exactly the same technique. It's just that we've just used a slightly different position. But it's exactly the same technique. The leg we're not using is bent up to protect the spine. That's fitted. The leg that we're trying to use is taken into extension. That fits. I'm holding on to the sacral apex. That fits. And he's using the iliacus. That fits. Exactly the same technique, just a different position.